today's program we have two sessions. The first one is a lecture by Dr. Sriram Prasad. He is a consultant neurologist and specialist in movement disorders from Rajagiri Hospital. He also works at Sriram Neurology Clinic, Chittoor Road. He'll be talking to us about Parkinson's disease, differential diagnosis and management, which will be moderated by our Professor Dr. M.G.K. Pillai, who is the HOD of Internal Medicine, Amrita Hospital. I invite both of you for the first sessions. Dr. Pillai.
Good afternoon to all of you. Parkinson's disease is actually a very evident neurological disease. Anybody walking with the disease, it will be easy for us to diagnose. Or very often we pray we should get a Parkinsonism for the examination. Just when we are doing UG training or even sometimes for post-graduation also, movement disorders, it's actually a good topic for discussion. But the thing is, when we practice medicine, a significant number of patients do come with atypical presentation. A couple of times we had some constipation cases or some minimal presentation, which often we may not be able to pick up. And of course, the recent trends in the management, after knowing the pathophysiology very well, so it has become an interesting area to deal with this movement disorder, especially Parkinsonism. So let us see the discussion or the details from our doctor. I think he will be an expert in this field. Over to you, sir.
Basically, when I entered here, I first asked whether some PGs are coming because I prepared to target PGs who are preparing for exams or who may get a case of Parkinsonism, as Sir was telling, for their exam. So straight away, we'll go to a topic. I have been asked to talk on differential diagnosis of Parkinson's disease. That is, I put the differential diagnosis of Parkinsonism and how to differentiate these conditions and a bit of management, which may not be that important for PGs. And if I get time, I will go to that. Otherwise, more thrust will be on differential diagnosis and how to identify different types of Parkinsonism. So this will be the scheme of my presentation. First, we should know what is the syndrome of Parkinsonism. Then we should know how to classify Parkinsonism. And there are certain common conditions which we get in clinical practice among the different types of Parkinsonism. So I will give emphasis on that and come to diagnostic criteria of those conditions, imaging features which may help to differentiate between these things, and at the end, certain clinical clues which may help to differentiate which type of Parkinsonism we are dealing with when we see a patient in our clinic. As well as, if time permits, I will go to management. Otherwise, we can even stop with that. Okay. So coming to the syndrome of Parkinsonism, the syndrome of Parkinsonism, the central feature is bradykinesia or slowness of movement. And it is defined as slowness of initiation of voluntary movement with progressive reduction in speed. As a patient goes on doing a tapping, the speed will come down progressively and amplitude of the repeated actions. Without bradykinesia or slowness of movements, we are not expected to make a diagnosis of Parkinsonism. So the central core feature is bradykinesia or slowness of movements. Along with that core feature, one among three other features should be present to make a diagnosis of Parkinsonism, like muscle rigidity of the limbs or axial rigidity. We will come to that later. 4 to 6 hertz rest tremor, that is a classical tremor described in Parkinsonism. I will show a video later. And postural instability should be present, but it should not be caused by any other secondary phenomena like a visual, vestibular, cerebellar or proprioceptive dysfunction. So it should be a primary postural instability because of the extrapyramidal dysfunction itself. So this plus one among the three is required to make a diagnosis of Parkinsonism. So that syndrome is made. Whatever be the type of Parkinsonism is there if they have this feature. Now next we go to classification of Parkinsonism. Basically, don't worry about this busy slide, I will explain. When we think about Parkinsonism, they are broadly classified into two. All Parkinsonisms are broadly classified into one is called typical Parkinsonism or Parkinson's disease. There is only one typical Parkinsonism, that is Parkinson's disease. All other Parkinsonism other than Parkinson's disease comes under atypical Parkinsonism. Okay. This Parkinson's disease or typical Parkinsonism, majority of them are sporadic, around 80% are sporadic, around 20% are familial, especially in young patients. Whereas in atypical Parkinsonism, it is classified into three: sporadic, familial, and secondary. But this familial is very rare, so we will leave that. We don't see it regularly in clinical practice. So basically, for our practical purposes, atypical Parkinsonism can be classified into two: sporadic and secondary. Sporadic is otherwise called Parkinson plus syndromes. There are four types: PSP, progressive supranuclear palsy, corticobasal syndrome, multiple system atrophy, and dementia with Lewy bodies. We will see all these things later. So familial atypical Parkinsonism we will leave because it's extremely rare. Don't bother about that. Secondary Parkinsonism, very important clinical practice. Three conditions. One is vascular Parkinsonism. Second is NPH. Third is drug-induced Parkinsonism. So when we think about Parkinsonism, which we see in clinical practice, the common conditions, when we see a patient with Parkinsonism, these 8 conditions covers more than 95% of all Parkinsonism that we see in our clinical practice, close to 99% probably. Parkinson's disease, 4 Parkinson plus syndromes, which are again degenerative: progressive supranuclear palsy, multiple system atrophy, corticobasal syndrome, dementia with Lewy bodies, and 3 secondary Parkinsonism, as I told, vascular, NPH, and drug-induced Parkinsonism. These 8 Parkinsonism will cover more than 95% of the Parkinsonism that we will see in our clinical practice. So we will concentrate on these conditions only. We will forget about all other conditions. Okay, so coming to the most common Parkinsonism, Parkinson's disease. So basically, how to diagnose Parkinson's disease? Again, there are these. He also, Dr. James Parkinson first discovered it around 200 years back, and then the inclusion criteria includes, again, single most important thing is they should have a Parkinsonism, the same syndrome which we saw just now. So done. So they should have a Parkinsonism. Once they have a Parkinsonism, then what all other things they should have? 3 out of the 3 or more of the 8 criteria, supportive criteria are required. What are the supportive criteria? Basically, it should be unilateral in onset. So that is one important supportive criteria, because Parkinson's disease by definition is asymmetric. We know that. The second thing is rest tremor should be present. Third thing is it should be a progressive disorder because it's a degenerative disorder. Fourth is persistent asymmetry affecting one side most. Even after 10 to 15 years of the disease, the side in which the disease started should be more affected. And then comes excellent response to levodopa, that is 70 to 100% response to levodopa. Severe levodopa induced dyskinesia, that is one supportive criteria. Levodopa response continuing for 5 years or more, and clinical course of 10 years or more. Now, when we go through this the diagnostic criteria, we just blindly read this, right? But think about a patient sitting in front of you. A patient who has got a Parkinsonism, which is recent onset, less than 1 year, bilateral onset. Put this criteria. Unilateral onset is gone. No rest tremor, so rest tremor is gone. Progressive disorder, maybe, because any degenerative disease is progressive. One criteria is satisfied. Persistent asymmetry. The symmetric disease means that's gone. Excellent response to levodopa. Most of the symmetric Parkinson's don't respond. I will come to that later. Severe levodopa induced score, again not seen. Levodopa response after 5 years means you have to wait for 5 years to put that criteria. So that is gone. And clinical course of 10 years or more, you have to wait for 10 years to put that criteria. That is gone. So only one will be satisfied. That is progressive disorder. In other words, in your clinic, if you see a Parkinsonism which is symmetric in onset, less than 1 or 2 years, most likely you are not dealing with the Parkinson's disease. That is gone. So simple. If you are seeing a symmetric Parkinsonism less than 1 year or 2 or 3 year course, that is not Parkinson's disease. Okay, that is some other Parkinsonism which we will come to later. Now, then there is a stringent exclusion criteria. Again, when we look at such diagnostic criteria, now when you see this busy slide, you will get lost, right? And our natural tendency is to turn that page and don't look at that so busy slides, right? So, but this exclusion criteria, if you look at it carefully, each and every criteria is meant to exclude a differential diagnosis of Parkinson's disease. If you apply like that, it's very easy. I will come to that. For example, look at this. History of repeated strokes with a stepwise progression of Parkinson's features. That is vascular Parkinsonism. We are excluding vascular. So one gone. I will talk about that later. History of repeated head injury, post-traumatic Parkinsonism. History of definite encephalitis, post-encephalitic Parkinsonism. History of oculogyric crisis, drug-induced Parkinsonism. Neuroleptic treatment at onset of symptoms, again drug-induced Parkinsonism. More than one affected relative, familial Parkinsonism, some rare Parkinsonism which I was talking about earlier. Sustained remission, naturally some secondary Parkinsonism, most likely drug-induced, otherwise most of them don't go for sustained remission. Strictly unilateral features after 3 years, most likely secondary to tumor or something which is very rare. Supranuclear gaze palsy, exclude PSP. Cerebellar signs, MSA. Early severe autonomic involvement, MSA. Early severe dementia with the disturbance of memory language praxis, DLB. Then Babinski sign, again any atypical Parkinsonism. Presence of cerebral tumor or communicating hydrocephalus, again secondary Parkinsonism. Negative response to large dose of levodopa, atypical Parkinsonism. And MPTP exposure, not seen now, but anyhow, toxin-induced Parkinsonism. So this makes sense. When you think like this, it makes sense, because each and every exclusion criteria is intent to exclude a type of Parkinsonism which we may see in clinical practice. Now, going ahead. So coming to features of Parkinsonism, again rushing because this I have already told. Motor problems I have already told. Non-motor I will come to later. Come to motor problems, again they are divided into cardinal features and other features. Cardinal features means the same diagnostic criteria. Well, the 4 features: rest tremor, rigidity, bradykinesia, postal imbalance, which we have already talked. Now come to this patient. Look at this patient. This is a classical rest tremor of a patient with the Parkinson's disease. This patient is around 1 to 2 years of the illness. He came to my clinic, and you are able to see the classical rest tremor of Parkinson's disease. Now look at the next video. This is a 15-second video. He is keeping his hands outstretched. There is no tremor. The tremor is gone. That is why it is called a rest tremor. When they attain a posture, the tremor is gone. That is why it is called a rest tremor. Now we'll stop there and then go to the next video. Now look at this video. After 15 seconds of keeping the hand outstretched, that same tremor comes back with the same frequency. This is a re-emergent tremor of Parkinson's disease. Once you see this type of tremor, there is no DD. This is PD. It is Parkinson's disease. Asymmetric onset, classical rest tremor, and re-emergent tremor. There is no DD actually. This is basically Parkinson's disease. Now, come to other features. Again, other motor features. I will rush through this because most of us know this. Mask-like face, decreased eye blink, low volume speech, micrographia, flexed posture, less arm swing, especially on the side of the side in which it is more affected. Gait problems like shuffling, festination. Festination is when they walk, the speed of their walking increases without their control, and they go like running. But that is without control, and they may fall. Freezing, again, when they walk, they get abruptly stuck without any reason, and they can't walk at all for a few seconds. That is freezing. And these are some of the gait problems seen. And coming to non-motor problems, basically there is a lot of non-motor problems. The importance is that many a times the disability of the patient is many a times because of the non-motor problems. Usually it is neglected because people believe that it is a movement disorder, so people concentrate on the motor symptoms. But this is very disabling many a times. For example, in the early stage of the disease, they may have depression, apathy, anxiety. As the disease progresses, late stage, memory and cognitive problems, psychosis, delusions and hallucinations. But very important, only in the late stage of Parkinson's disease. Atypical Parkinsonism, it can come early, which I will come to later. Sleep problems, again, sleeplessness, insomnia, REM behavioral disorder, extremely important, a feature of most of the sign nucleopathies, including Parkinson's disease. Then excessive daytime sleepiness, again, very common. Coming to disturbance of autonomic nervous system, urinary disturbances, especially extremely common. In the early stages, they have increased urinary frequency and urgency, later develop incontinence. Constipation, very common, one among the premotor features of Parkinson's disease. Sexual dysfunction, common. Sweating abnormalities, drooling of saliva are common. And again, as the disease progresses, the patient can have a pain and numbness of limbs, especially when during the off state, when levodopa is not working, which I will come to later. Fatigue, very common. Alteration smell sensation or anosmia, extremely common. And it is a very important feature of Parkinson's disease, premotor symptom. Then, most of the patients, more than 95% of the patients, we can make a clinical diagnosis. No imaging is required to make a diagnosis of Parkinson's disease. If there is a doubt, real doubt, especially between drug-induced Parkinson's or something, people can try a DAT scan. Usually, I don't do it in my clinical practice because most of them can be diagnosed clinically. And if you do a DAT scan, you will see that there is an asymmetric uptake of the dye on the putamen, and the left side is more affected here, which means that patient may have a right-sided onset of the disease, and this is a control. Coming to, we will leave Parkinsonism there. Now we will go to Parkinson plus syndromes. One among the most common things among the Parkinson plus syndromes we see is progressive supranuclear palsy. Coming to PSP, again, diagnostic criteria. I have put diagnostic criteria in all these conditions, but forget about that. I will try to simplify it. And in diagnostic criteria, they always put a definite criteria, means we need an autopsy, because only after a patient dies, we need a brain autopsy to prove histopathologically whether it is confirmed or not. So all these criteria, the maximum we can attain is probable Parkinson, probable PSP, or probable whatever Parkinson's it is. So when you think of PSP, think two things. One is a supranuclear palsy, basically a gaze abnormality of the, especially vertical gaze abnormality. Plus, second most important thing is falls, early falls. So think PSP, think two things. One is supranuclear gaze palsy, second is early falls. So if both either vertical supranuclear gaze palsy or both slowing of vertical second and posterior instability to fall with less than 1 year of disease onset is possible supranuclear palsy. Whereas probable supranuclear palsy is vertical supranuclear palsy and prominent posterior instability to fall within first year of illness. If both occur within first year of illness, then it is probable PSP. If either one among them occurs within 1 year of illness, then we can call it as a possible PSP. Definite, as I told, after autopsy only. Then there are certain supporting criteria. I talked about asymmetry and symmetry earlier, right? So when we think about a PSP, usually our thought is it's a symmetric disease. This is not always correct. I will come to later. But usually in supporting criteria, they tell, sorry. Symmetric echinacea rigidity, proximal more than distal, abnormal neck posture, always we think axial more than appendicular is PSP, and that is correct to a certain extent. Abnormal neck posture, especially retrocolis. Then poor response to levodopa, early dysphagia and dysarthria, early onset of cognitive impairment, all this may favor a PSP. And again, when coming to exclusion criteria, always think the DD. Recent history of encephalitis, naturally post-encephalitic Parkinsonism, alien limb syndrome, corticobasal syndrome, cortical sensorineural corticobasal syndrome, focal frontal or temporoparial atrophy, again, either frontotemporal dementia or a temporoparial atrophy means it's again Alzheimer's disease, hallucination or delusion unrelated dopamine therapy, that is dementia with Lewy bodies, cortical dementia of Alzheimer's type, Alzheimer's disease, prominent early cerebral signs and unexplained dysautonomia, MSA. So these exclusion criteria always targets a disease. Think about that disease, then you know it. Okay, then coming to, but as I told earlier, when we think of PSP, we always think of a symmetric disease, right? But that's not always correct. PSP, there are 3 types, especially 2 types are common. When you see a patient with the early falls and a supranuclear gaze palsy, always look at symmetricity. Symmetric means it's called Richardson syndrome. Asymmetric is called PSPP, PSP Parkinsonian variant. And they usually have tremor. Yes, they can have a rest tremor as well. So basically there are two variants. One is Richardson syndrome and other is PSP Parkinsonian or the PSPP. PSPP is asymmetric, the other is symmetric. So the classical PSP which we all know is Richardson syndrome, symmetric Parkinsonism with the falls and supranuclear gaze palsy. Right. So this is a study just to highlight that in case of PSPP, tremor, asymmetric onset and response to levodopa is better. All other things, symmetricity, falls, these are with the Richardson syndrome. And coming to the third variant, why I am putting this is because this comes as a differential diagnosis of certain lower body Parkinsonisms. Basically, there is a variant of PSP which is called pure echinacea with the gait freezing. They have predominant gait problem, no other issues. Even upper limb, there may not be bradykinesia, there may not be tremor. Only predominant issue is gait freezing even after many years of the illness. Even after 5 years, they only have gait problem, they have falls, but no supranuclear gaze palsy, no other features. So this is a third variant, but not that common as that of the other 2 variants. So then there are certain radiological signs, named signs in PSP, which will help us to make a diagnosis. One is the hummingbird sign, which we all know about. That is basically the tegmental atrophy. When we look at the tegmental atrophy from different angles through different parameters, you will define different signs. That's it. The same thing which looking from different angles. So this is the tegmental atrophy seen, the midbrain atrophy, and some people have compared it to hummingbird, some to penguin or whatever. Anyway, it's one and the same thing. And the same thing can be seen in the axial images as a morning glory sign because the concavity is more here because of the tegmental atrophy. Then people have measured actually through studies more than the AP diameter of the midbrain at the level of the superior colliculus. More than 18 is normal, and in PSP it is usually less than 14. But this needs measurement. This cannot be done in a clinic when we see the imaging alone in the console. Okay, and this is a diagram which shows the progressive atrophy of the midbrain as time passed by. And then some patients we can see a hyperintensity, T2 hyperintensity in the tegmentum. And this is again again seen in few patients only, not in all patients. And this is one among my patients which I saw in last week in Rajagiri. Basically, look at this. Look at the eye movement of this patient. I am asking the patient look first horizontally. His horizontal saccades itself is low. He is trying to look towards the right then. Now I am asking him to look up. Basically, you can see the frontalis is contacting. He is trying to look up, but his eyes are not coming. This is classical severe supranuclear gaze palsy of PSP. And sound one now. അടുത്ത വീഡിയോ ഇട്ട് മതി, കുഴപ്പമില്ല. So, and this is the imaging of the patient. Basically, they came with an imaging which was done 1 year earlier. The same patient's imaging. We can see early atrophy of the midbrain here. So, this was done in last October actually, last September 2023. Basically, 1 year later, I am seeing the patient. He has severe supranuclear gaze palsy, and even in this image itself, we can see an early midbrain atrophy. Then, coming to the second progress, second Parkinson plus multiple system atrophy. Before going, think MSA, think autonomic. It is not multiple system atrophy, this is multiple system autonomic. Think MSA, think autonomic. Okay, that's the most important feature. So, and the MSA with, and again MSA is classified into two, MSAP and MSAC. If the patient's predominant symptom starts as cerebellar, then it is called MSAC. If the patient starts with the Parkinsonism along with autonomic, then it will be called as MSAP. So, just like dividing PSP into two, we can divide into two depending upon what symptoms started first. So coming to the criteria again, the most important thing to emphasize here is autonomic failure. For a probable MSA, autonomic failure is required. How is autonomic failure defined? Either urinary incontinence along with the erectile dysfunction if the patient is a male, and an orthostatic decrease in BP of 30 millimeters of systolic or 15 millimeters diastolic. Usually we take 20-10. But for an autonomic failure definition for MSA, there should be a reduction of 30/15 millimeters of mercury BP. And along with this, either you need a Parkinsonism or we need a cerebellar ataxia, cerebellar syndrome. So if it is Parkinsonism, that is called MSAP. If it is cerebellar, it is MSAC. So simple. But autonomic failure is required. Without that, we can make a diagnosis. To make a diagnosis of possible MSA, again, autonomic failure is not required. Autonomic dysfunction is enough. Autonomic dysfunction means urinary incontinence is not required. Even frequency, urgency, and incomplete bladder emptying is enough. And again, a BP, orthostatic BP decline is significant, but not coming to 30/15, which means up to 20/10, we can take it as an autonomic dysfunction. Then that will come to only to possible MSA. And again, we have to add one among these three, and one among these two, either Parkinson's or cerebellar ataxia. Okay, and very important, one more point, age should be more than 30 years. There is no MSA below 30 years of age. Okay, then coming to additional features of possible MSA, I will not go into all these features because many of them will come later, but stridor is very important. In a patient with a typical Parkinsonism, Parkinson plus syndrome, if the patient has got significant stridor, think MSA. First diagnosis MSA, and probably most of these people are MSA. The other conditions usually doesn't produce. Then coming to, this is an important slide. Supporting features and non-supporting features for MSA. Supporting features, again, orofacial dystonia or even dyskinesia. We talked about severe dyskinesia in PD, right? Levodopa-induced dyskinesia. But MSA is another condition which can have levodopa-induced dyskinesia. But the distribution of dyskinesia is different. Usually it is perioral. They will have dyskinesia like this will be usually dyskinesis in MSA patients. Then disproportionate androcolis. If retrocolis is seen in PSP, androcolis is seen in MSA. Okay, camptocormia. Camptocormia usually in MSA, and again PISA syndrome. These are two types of dystonias, axial dystonias, depending upon to which side it goes. Camptocormia or PISA syndrome again in MSA. Contractures of hands and feet, late stage of MSA. Inspiratory sigh along with the stridor especially in MSA. Severe dysphonia again MSA. Severe dysarthria can occur in any atypical Parkinson's. Anyhow, new or increased snoring again MSA. Cold hands and feet can occur because of autonomic, pathological offer crying, any atypical Parkinson's. This is important, jerky myoclonic tremor. Usually when we see a patient with the Parkinson's, and many times one confusing thing is whether it is a tremor or a myoclonus. Tremor is this one, which we saw in that video in PD. Whereas myoclonus is jerky like this. It's a jerky tremor, most likely it is myoclonus, and we are dealing with an atypical Parkinsonism, not PD. Then coming to non-supporting features, again, classical pill rolling tremor, PD. Clinically significant neuropathy, again not MSA because we may be dealing with a primary neuropathy syndrome. Hallucinations not induced by drug, DLB. Onset of age more than 75 years, unlikely. Less than 30, no MSA. Family history of ataxia or Parkinsonism, we are dealing with SCA most likely, spinocerebellar ataxia. And dementia naturally not in MSA. And white matter lesions of okay, then it's another secondary condition. Okay. Anyhow, then again there is one important named sign of MSA, that is hot cross bun sign. Hot cross bun sign is in MSSC because of the significant atrophy of the brainstem. And this is a classical hot cross bun sign. This is from the literature, but this is one among my patients who had a in T2 images showing hot cross bun sign, MSSC. Then coming to, and again in MSSC patients, it's not hot cross bun sign alone. There is infratemporal atrophy. Basically, it affects everywhere, including the cerebellum, and the cerebellar peduncles and all can be seen. Then coming to another, but when it comes to MSAP, Basically, it is putaminal atrophy, hyperintense rim sign, this hyperintense rim seen in the putamen, and putaminal hypointensity in a T2 weighted image. These are seen in MSAP. Okay, then yeah, so we will leave MSA there. 2 are over. Now 2 more Parkinson plus syndromes. So third is corticobasal degeneration or corticobasal syndrome. Now corticobasal degeneration is basically a pathological diagnosis. So the term uses corticobasal syndrome because when we make a clinical diagnosis. So coming to corticobasal syndrome, think of corticobasal syndrome in 2 ways. One, they have cortical signs. Second thing is basal signs, which means that basal ganglia or extrapyramidal signs. The other thing is cortical signs. So what are the cortical signs? The cortical signs are, first we will go to the extrapyramidal signs or the basal signs, including limb rigidity or echinacea, again Parkinsonism, limb dystonia, limb myoclonus, extremely important. Dystonia and especially dystonia predominating early in the disease and an asymmetric onset, that is most likely corticobasal syndrome, not PD. This is one DD of PD because this is also asymmetric. I will summarize it later regarding symmetricity. Then coming to cortical signs, what are the cortical signs? Apraxia, very important. Cortical sensory deficit, alien limb phenomena, very rare, extremely difficult to see, very rare, but if it is there, it is very important. Okay, so to make a diagnosis of, so these are the 3 cortical and 3 basal signs. To make a diagnosis of corticobasal syndrome, possible corticobasal syndrome may be symmetric, but usually it is an asymmetric disease. For we can make a possible corticobasal syndrome even with the symmetricity if one among these 3 are present. One among the 3 cortical, one among the 3 basal signs are present, means we can make a diagnosis of possible corticobasal syndrome. So next is symbol probable. I missed a slide. Probable corticobasal syndrome, 2 out of 3 should be present. 2 cortical signs, 2 basal signs. Then probable corticobasal syndrome, 1 present means it is possible. And again, coming down. Yeah, and what in imaging what we see in PSP, we usually, when it comes to cortical atrophy, it is frontotemporal atrophy which is seen in PSP. Okay, whereas when it comes to corticobasal syndrome, it is frontoparietal atrophy, frontal as well as parietal atrophy, this differential or asymmetric parietal atrophy. And I will show you a video. Look at this patient. This patient I saw last week in my clinic. This limb is dystonic, including the fingers, as well as there is a dystonia at the elbow joint as well. When we see this posturing, this much of dystonic posturing along with the severe rigidity and probably myoclonic jerks, most likely corticobasal syndrome. This is not PD. Usual mistake is because this is asymmetric, we may think that this is PD. Okay, now the same patient's MRI, we can see the differential atrophy of the frontoparietal atrophy. If you look here, this lobe is more atrophied when compared to the other side. So basically this is correlating with the corticobasal syndrome. Then this is another patient which I saw in Rajagiri last week with again an advanced corticobasal syndrome. I put this only to show as the disease advances, it can become bilateral. The patient has got a fisted position here and patient has got a severe dystonia here. She had a left-sided onset and this hand is more dystonic when compared to right, and even at any stage of disease, this asymmetry is maintained. Left will be more when compared to right. And in the same lady, when I ask her to outstretch her hand, we can again see the severe dystonic posturing of her left hand, which is almost in a fisted posture, and on the other side also it's there, but there is an asymmetry. Again, going down, the same patient's lower limb, it can naturally affect the lower limb as well. In the lower limb also, we can see a asymmetric dystonia. The left lower limb, left foot more affected when compared to the right. So this is corticobasal syndrome, and we will leave it there. The fourth Parkinson plus syndrome, that is dementia with Lewy bodies. As the name indicates, dementia is a very important feature. Without dementia, it's difficult to make a diagnosis of DLB. I will come to a diagnostic criteria, and there is a 1-year rule which is usually applied. If the patient starts with the Parkinsonism, dementia should come within 1 year, and if the patient starts with the dementia, Parkinsonism should come within 1 year. Especially for research criteria, they put this. For clinical diagnosis, they allow a small leverage, but for research criteria, for purity, it's very important. So coming to, there are 3 features: central feature, core feature, suggestive features. Central feature is nothing but dementia. Think DLB, dementia with the Lewy body, dementia. Okay, what are the important features of that dementia? They have more attention problems, executive dysfunction, visuospatial ability. It's not memory. whereas it is frontal dysfunction usually. And there are core features, very important. Fluctuating cognition. Fluctuation is a very important feature of DLB. Fluctuating cognition, think DLB. Recurrent visual hallucinations, especially formed visual hallucinations. They see real images. And then spontaneous features of Parkinsonism. Again, then suggestive features. Suggestive features are again REM behavioral disorder, which is seen in PD as well. Severe neuroleptic sensitivity, which means that if you give a 1 milligram of risperidone, they worsen like anything. Their Parkinson's worsen like anything. So these two are suggestive clinical features. Now, so probable DLB means central feature should be there plus 2 core features. Or central feature is dementia plus 1 core feature and 1 suggestive feature. Forget about this. These 3 features should at least be present. We can learn like that because it's not at all possible to mark up these things and make a clinical diagnosis. Possible DLB, central feature should be there and 1 core feature or 1 or more suggestive feature should be there. Anyhow, core feature is dementia. Now, so we leave Parkinson plus syndromes there. So 5 conditions are over. PD, PSP, MSA, CBD and DLB is over. Now, 3 secondary Parkinson's which are common in clinical practice. Vascular Parkinson's are very important. We all have seen this condition. So, the older patients with a shorter duration of illness, lower body Parkinson's, vascular Parkinson's, always think lower body Parkinson's. They have predominant walking difficulty. And again, dementia may be present because of the bilateral pyramidal involvement. Tremor not at all a feature. No response, usually don't respond to levodopa. And neuroimaging will show in most of these cases. I will come to that later. So, and coming to diagnostic criteria, naturally they should have a Parkinsonism. And they should have a cerebrovascular disease, right? To make a diagnosis of vascular Parkinsonism. That cerebrovascular disease can either be a clinical stroke. If they had a clinical stroke, acute stroke, within 1 year Parkinsonism should come. Otherwise, they should have a progressive Parkinsonism and extensive subcortical white matter lesion to correlate a vascular Parkinsonism, even if they don't have a clinical stroke. We see an MRI which is suggested, then we can make a diagnosis. I will come to this image. Yeah. We all have seen such images, right? Lot of white matter changes in the subcortical white matter, in the basal ganglia, thalamus and things like that. This, even if there is no clinical stroke, a patient has got a lower body Parkinsonism, and if you are seeing this image, you can fairly make a diagnosis of vascular Parkinsonism. And then coming to the next secondary Parkinson's, NPS, very important, and many a times an overdiagnosed entity, to be honest with you. Most common form of hydrocephalus in adults, and it is a communicating hydrocephalus. And the most important features are disorders of gait impairment, incontinence, and dementia in the presence of ventriculomegaly. And one among the features of, one among the treatable causes of dementia, very important, especially if you pick it up early, most common in more than 60 years of age, and there is no sex predilection. So coming to the triad is gait, cognition, bladder, as we saw. Gait problem is seen in almost 100% of patients. Cognitive impairment close to 80 to 90%, and urinary dysfunction again close to 80. But the presence of all the 3 together in a patient at a single time is seen only in around 50 to 60% of patients in different studies. So in other words, all these 3 features simultaneously are not needed to make a diagnosis. Okay. Then coming to gait in NPS, just I will touch upon the gait alone in NPS. Basically, if the NPS produces symmetric gait involvement, unless there is a secondary cause or a local problem. So otherwise it is symmetric. And again, the gait, the 2-3 types of gait are described. Magnetic gait, broad-based gait, this is the most common type. Broad-based steps with the short strides, and a marching type of gait may also be seen. This is Parkinsonian gait. We will leave that for the time being, which we have already discussed. So we will leave that. So there are 2 imaging features which has been described to make diagnosis of normal pressure hydrocephalus. One is Evans index, very important. What is Evans index? Basically, you take the widest diameter of the frontal horn and take the widest diameter of the brain at any area. Divide the widest diameter of frontal horn to widest diameter of brain. If it is more than 0.3, then it is a supportive feature, not definite, but a supportive feature of NPS. Yeah. Then coming to next is callosal angle. Callosal angle basically an acute angle. This will be close to around 50. This is in one among my patients. I will come to that. And an acute callosal angle less than 90 degrees, if you see, it is again suggestive of NPH. And I will come to a case which this patient is now admitted in Rajagiri. 60-year-old male came with the progressive gait difficulty, some bladder disturbance and cognitive dysfunction. And MMS was 23 out of 30. He had a predominantly lower body Parkinsonism. Look at this video. This is before doing a CSF tap. He is undergoing CSF tap now. Second CSF tap was done today. We can see the broad-based gait of broad-based but short stride, small stride length, classically seen in NPH. He has to catch somewhere, otherwise he's not that confident. Then coming to the next, this was yesterday his first CSF tap was done. This is the video after that. His gait is probably better, not very sure, but after the first CSF tap. Second tap was done today. Yeah. And this, again, this is the MRI of the patient, and axial images, which shows the, in this patient, the Evans index was 0.49, very high Evans index. And again, there are no white matter changes, so this is most likely NBS only. And again, the callosal angle, the acute callosal angle can be seen in this coronal sections. So then, the last among the 8 conditions which I was talking about, drug-induced Parkinson's, I have not put anything, only a video. This patient came to Rajagiri some 2 months back, and she was on antipsychotics. She had epilepsy with a psychosis from young age onwards. She was on risperidone. And this is the video of the patient. When it comes to drug-induced Parkinsonism, usually it is not Parkinsonism alone. They have other drug-induced movement disorders. For example, this tremor of her lips and jaw is not seen in degenerative Parkinson's. This is usually seen in drug-induced Parkinson's, and this is very reminiscent of tardive dyskinesia. When we see this condition alone without Parkinsonism, we make a diagnosis of tardive dyskinesia, right? So, and along with that, the patient will have Parkinsonism. Patient may have other features as well of tardive dyskinesia, like tardive tics or tardive stereotypies and things like that can be seen. So this patient has got a symmetric Parkinson's, and drug-induced Parkinson's is usually symmetric. They usually have a perioral or lingual tremor or dyskinesias, and along with that they have a symmetric Parkinsonism. So basically, should I show the full video or? The most common drugs are antipsychotics only, but some one drug which is very notorious and very commonly used in clinical practice is levosulfrate, extremely common. So I never use it in my clinical practice because I see the end of the thing. So because I see these patients with the movement disorders, maybe in 100 patients, if you use 2 or 3 people develop, but I am seeing that 2 or 3 patients in my clinical practice, so I don't use this drug at all. Levosulfrate, very notorious to produce. Then flupentixol, melitrazone combination, extremely notorious to produce. So this is drug-induced Parkinsonism. So these are the 8 conditions which are most commonly seen in clinical practice. Now, I summarized because from this clinical clues, how can we reach which type of Parkinsonism we are dealing with? Symmetricity. As I told, asymmetric Parkinsonism, PD, PSBP, corticobasal syndrome, and these are the 3 most common asymmetrical Parkinsonism. Whereas if it is symmetric Parkinsonism, Richardson type of PSP, MSA, dementia with the Lewy bodies, and then the secondary Parkinsonisms. Then again, this coming to distribution, whether it is lower body Parkinsonism, lower body Parkinsonism, 3 conditions. Again, vascular Parkinsonism, NPH, and the gait freezing variant of PSP. These are the 3 lower body Parkinsonisms. Rest tremor, classical in Parkinson's disease, can be seen in PSPP as well. Progression. Naturally, all these diseases are progressive except secondary Parkinsonism. Probably the only thing which is not progressive, even among secondary Parkinson's, is drug-induced Parkinson's. So if you stop that drug, the patient comes back. The earlier patient improved significantly after stopping risperidone. I don't have a follow-up video, sorry. And again, postal instability. Postal instability, predominant postal instability early in the disease, PSP. Supranuclear gaze palsy, PSP. Bulbar dysfunction can be seen in any atypical Parkinsonism. Pseudobulbar effect, again, any atypical Parkinsonism. Pyramidal sign, any atypical Parkinsonism. Inspiratory respiratory dysfunction, cerebellar signs, autonomic, think MSA. Dementia with the Lewy bodies or corticobasal syndrome. Psychosis, again, dementia with the Lewy bodies. RBD, any synucleinopathy like PD, MSA or DLB. The 3 conditions can have RBD. Anosmia, most likely PD. Anosmia is more specific for PD than other synucleinopathies like DLB or MSA. So this is how, with the clinical clues, we can think of a type of Parkinsonism. So this is how, then again, just but none of us go through the diagnostic criteria, make a diagnosis in our clinic, right? It's not possible. It's not possible to mark up all these 9 criteria, sit in a clinic and make a diagnosis. 8 conditions. Then in a single sentence, I will summarize it for you. Asymmetric onset with the rest tremor, severe dyskinesia, that is PD. Then supranuclear gaze palsy and falls, it is PSP. Asymmetric means PSP-P, symmetric means Richardson syndrome. Think autonomic, predominant autonomic manifestations, that is MSA, either MSA-P or MSA-C. 4th is corticobasal syndrome, again asymmetric significant cortical signs, dementia, that is, and the classical fisted position of the limb, dystonic fisted position of the limb, that is corticobasal syndrome. Fifth is dementia with the Lewy bodies, predominant dementia early in the part of the disease, especially the fluctuation, visual-spatial disorientation, inattention, that is DLB. Then predominant lower body Parkinsonism may have a stuttering course, and along with the vascular features of MRI, that is vascular Parkinsonism. Again, predominant lower body Parkinsonism with a significant ventriculomegaly, that is NPH. And again, symmetric Parkinsonism with in the context of an offending drug, that is the drug-induced Parkinsonism, and they improve once you withdraw that drug. This is how we can, in a single sentence, we can think about this or learn about this in a single sentence to see in clinic and make a diagnosis quickly. So coming to management, do we have more time or I am done? Okay, 5 minutes there. Management, I will tell in brief. So when to treat? Just because we make a diagnosis of Parkinson's, should we start treatment? No. Because what are we offering? We are only offering symptomatic treatment to improve their activities of daily living and quality of life. So if a patient with a PD who has got a very mild tremor doesn't affect his activities of daily living, why should you start treatment? No need. We can always postpone treatment. So because there is no definite disease modifying agent. Then coming to what medications are used, I will just touch upon the medications alone. Levodopa, the cornerstone of treatment for any type of Parkinsonism. Dopamine agonist works only in Parkinson's disease. This group of drug usually doesn't work in atypical Parkinsonism. If at all it produces side effects rather than benefits. So I don't use it for atypical Parkinsonisms. Then coming to MAO-B inhibitors, rasagiline and sulfonamide, again only beneficial for Parkinson's disease, not for any other Parkinsonism. Doesn't work. COMT inhibitors, when the disease progresses and they have fluctuations, we can use and add entacapone to levodopa. Then amantadine can be tried in atypical, especially amantadine is a good drug which can be tried along with the levodopa in atypical Parkinsonism, especially those patients with the gait problems and speech problems. Amantadine can improve speech and gait, means in other words, axial features. Coming to initial treatment is used, as I told, we need not start treatment once we make the diagnosis, only if it affects his activities of daily living. And if it is a very mild Parkinson's disease, we can start with the MAO-B inhibitors like rasagiline or something like that. And eventually most of these patients will require levodopa at some point of time in their life. So once we start levodopa, then problems start, right? Based on the response to levodopa, there are 3 stages. Initial phase is called honeymoon phase. Why? Because with the 3 doses of levodopa, they get round-the-clock benefit. The doctor is very happy, patient is very happy for around 4 to 5 years. But after that, problem starts when they go to the second stage of motor fluctuation, where they develop on phase as well as off phase. On phase is when the levodopa works, their symptoms are less. Off phase, levodopa doesn't work, all the symptoms come back and they have problems because of the symptoms. And then third phase is phase of dyskinesia. During the on time, when the levodopa is working, they have developed unwanted movements, which I was talking about when I talked about the diagnostic criteria. Severe levodopa-induced dyskinesia, classical of Parkinson's disease. Now, this is one patient who is in the stage of motor fluctuation. Look at this video. This is off state. This video is done during the levodopa challenge test, which is done before DBS. And this patient underwent DBS at Rajagiri and some 2-3 programming sessions done. This is off state when the drug is not working, but this is his on state. Once his levodopa works, he is much better. This is a stage of motor fluctuation. Okay, and this is the stage of dyskinesia. This is on stage, and again this video is recorded during her levodopa challenge test, and she underwent DBS at Lourdes Hospital and now doing much better. I will show her follow video later. Severe dyskinesia affecting her whole body. She was working in a bank, and imagine the situation how she can work in a bank with this much of dyskinesia. She quit her work, did DBS, became better, and now she is again has gone back to her work. I will show her video again later. Then, so once these stages occur, when there is an advanced Parkinson's disease with the motor fluctuation dyskinesia, what are the options? We have got an apomorphine injection option. Many people might have seen a video which was given by Nanavati Hospital showing a person going in a wheelchair. He is getting an injection, and after 5 to 6 minutes, he gets up and walks and makes push-ups and all. But that is very correct. But they didn't tell one point there. This effect lasts only 1 to 1.5 hours. They marketed this as a new treatment, a magical treatment which is going to cure Parkinson's disease with a single injection. That was part of a marketing strategy. But this part, till the other point, the improvement is correct, but lasts for 1 to 1.5 hours only. So apomorphine injection is used in two ways. One is as discrete injections, like subcutaneous injection, just like insulin patients can take. That is done to tide or off state. When the patient is in off state, for example at night, if the patient wakes up in the night and they want to go to washroom, they are off, they can't move. So they can take an injection. 5 to 6 minutes later, that the patient becomes on. They can go to the washroom and do all their needs and come back to bed. 1.5 hours, the effect goes off. But they have done their work. And then they can sleep well. And even in daytime, when they have frequent offs, they can try apomorphine injection, discrete injections, which will help them for 1.5, maximum 2 hours. And second is as pump. This apomorphine pump is given as continuous infusion, and it is given for around 16 hours. That is wakeful hours. Morning, when the patient wakes up, he will start the pump. When he goes to bed, he will switch off the pump. So that is the second use of apomorphine injection. I had two patients, one who used injection, other who used a pump. The problem with this problem here is availability. There is no company support. We can't do any of these things without company support. So the availability of the drug is a big problem. Among the patient who is using that pump, many times I get call telling that we are not getting the drug and things like that. So we have to sort it out by contacting them. Anyhow, and third most important thing is deep brain stimulation. And the most important treatment used nowadays in advanced Parkinson's disease. And I will just summarize. What we do in DBS, we have to put this device into the body of the patient. This is basically the neurostimulator, and this is the lead which goes into the brain of the patient. We'll show more images. So there are 3 companies which supply these things. 2 are available in India. Anyhow, targets are, in Parkinson's disease, target is either subthalamic nucleus or GPI. Thalamus is for tremor alone. And once DBS is done, the image will look like this. This is the 2 tracks through which DBS has been done. These are the 4 contacts on both sides of the brain. And there is a software called SureTune where you can see the subthalamic nucleus and the tip of the leads inside, well placed inside the subthalamic nucleus. This is one among my patients who earlier underwent DBS at Rajagiri Hospital. Anyhow, and this is another patient. I will stop with the 2 more videos, and two videos will show the good results of DBS. And this was the first patient who underwent DBS at Lourdes Hospital. My first patient at Lourdes Hospital underwent DBS. This is off state. And when he's on, the problem is that he develops this funny type of dyskinesia affecting his right lower limb. He had a right lower sided onset of Parkinson's disease. And he has this very peculiar type of dyskinesia which affects his right lower limb predominantly when he's on. Imagine a condition where the patient, during on state itself, the patient is like this. Most of the time he was lying in the bed with this dyskinesia. So it was extremely disabling, severe type of dyskinesia. Usually, in such asymmetric dyskinesia is usually not very common. When they develop dyskinesia, they usually have an asymmetry because the side at which disease started have more dyskinesia. But this dyskinesia affecting one side alone in an advanced Parkinson's disease is not that common. He was developing this peculiar type of dyskinesia, again affecting lower limb alone, right lower limb alone. And we did DBS for this patient, and after 3 years, he is like this. Remember the other patient who had severe dyskinesia? Look at her off state. The other video was on state with the dyskinesia. This is her off state. Severely bradykinetic. More effect on the left side when compared to the right. And 2.5 years after DBS, she is like this. Her dyskinesia is completely gone, and she has gone back to her work. She still works in her bank, and she's close to her retirement. I believe she's retiring within 6 months or so. And she's still under follow-up. This is a 2.5 years of follow-up after DBS. In a carefully selected group of patients, DBS can do wonders. But the problem is that if you start doing DBS for all Parkinson's patients, naturally the result is going to be disastrous. And there are stringent inclusion and exclusion criteria. I did not put this because that is not within the scope of this discussion, because it will make things more and more boring. Probably I have bored you enough through my talks till this time. So I'll stop here. Thank you.
Sir, thank you for the presentation. It is highly informative. But any questions or doubts?
Usually, when we see a patient with Parkinson's disease or any type of Parkinsonism in our clinic now, at least 20% of people will tell, I had a trauma. So usually we get this question. But post-traumatic Parkinsonism, to be honest, is not very common. And there should be severe injury to the head. Either repeated trauma or even a single head trauma with a diffuse axonal injury or severe injury to the head. Unless that occurs, usually post-traumatic Parkinson's is not that common. That is why I didn't put that inside the common groups. Post-traumatic Parkinsonism, proven post-traumatic Parkinson's clinical practice is not that common. And occurs
one famous
Muhammad Ali, yeah, I know. And that is a problem. Muhammad Ali, the people will ask, any idiot, Parkinson's. No, all these things doesn't happen. Unless there is a very severe injury or repeated injuries, this usually doesn't happen. Less common in clinical practice, to be honest.
Then this writer's syndrome, writer's cramps, is it a forerunner of Parkinson's?
No. Why? Because writer's cramp is basically dystonia. It is a task-specific dystonia. Writer's cramp is not a forerunner of Parkinson's. Probably the question comes from many people, who has got Parkinson's disease. Usually it is an asymmetric disease. And if it starts from the right side without tremor, most of these people's first complaint will be difficulty in writing, because that is one among the most common job which we do with the right upper limb. And the second thing is eating probably. But writing requires more coordination. So it is not uncommon for Parkinson's disease to start with the difficulty in writing as the first symptom. That is not writer's cramp. Writer's cramp is entirely different. It's a task-specific dystonia. So we should differentiate between these two. Probably people confuse that writing difficulty as the first symptom of Parkinson's disease with a writer's cramp, which is a task-specific dystonia. Sir, among the rivastigmine does not have significant role in the motor features of Parkinsonism, except for one condition. When a person with the Parkinsonism has falls in Parkinsonism are usually multifactorial. It's not postural imbalance alone. Attention plays a very important role. So one theory or one school of thought is that inattention is one among the causes for falls in Parkinsonism. This inattention is one among the postulated causes of falls in Parkinsonism, or a contributing factor to falls in Parkinsonism. So in such cases, if the patient has got significant falls, especially there are features of dementia, then we can try rivastigmine. There are many people who try rivastigmine or even donepezil or whatever for people with the falls which is not responding to any other drugs. For example, you tried amantadine, not responding. You have limited options with the falls, right? Except for physiotherapy and walking aids. Then we can try drugs like rivastigmine. Other indication, naturally, PDD, Parkinson's disease is a dementia, or whatever Parkinson's with a dementia, we can try. But even in motor symptoms, for falls, there is an indication. Sir, if you ask me, people who had Parkinsonism, who were having Parkinsonism before the COVID era came, when they had COVID, they had severe worsening of Parkinsonism. That was very common. That is published as well. Severe worsening of Parkinsonism during the COVID period. Many people come back to baseline, but many people may not as well. The progression which they had done during that time may only partially recover. They may not fully recover. But COVID infection as a primary cause of Parkinson's disease, I don't think there are enough published information to make a comment like that. But yeah, exactly. Definite worsening was there. That is correct.
If you know syphilis, you know half of medicine. If you know syphilis, you know half of medicine. In the 80s and 90s, we used to say, if you know HIV, you know half of medicine. Now people say if you know COVID, you know half of medicine. So, because it affects almost all systems. So you notice that there is a
Worsening of
rapid
Parkinsonism
deterioration in Parkinsonism also.
Some people come back to baseline, some people may not. Partial
you.
recovery only may occur.
Thank you.
Thanks.
What about the cost of this DBS?
Yes. Cost of DBS, basically there are two types of neurostimulators, rechargeable and non-rechargeable. With the non-rechargeable neurostimulator, which usually lasts for around 5 years or so, we can do for 12 lakhs and on. With a rechargeable device, it comes to around 18 lakhs. That lasts for 15 years, but.
Dr. Sriram.
Yes.
No more questions?
One question, last question.
Yeah.
Tremor predominant Parkinsonism sometimes is difficult to differentiate from essential tremors, especially in the earlier stages when the other features of Parkinson's may not be there.
Yeah.
What do you do?
Good question, sir. I will answer. We are seeing a patient with a significant tremor, less bradykinesia, or only bradykinesia may be elicited only on examination. Patient may not even come up with the symptom of bradykinesia. That is the most common clinical situation we start is talking about, difficult to differentiate. The most important feature is rest tremor predominant, that is PD. The patient, as the video I showed, when they attain a posture, that tremor either stops or decreases in severity. And again, it may come back as a re-emergent tremor, that's a different thing. Whereas in an essential tremor, either rest tremor is not present at all. Even if there is rest tremor, postural and intention tremor is more severe. The severity of tremor increases when they attain a posture or when they do the finger nose tap test. So rest tremor more and the rest tremor goes off or severity decrease on attaining a posture, that is PD. And rest tremor is either not there or slightly there. When they attain a posture, that increases in severity, and when they do this, that increases in severity, that is essential tremor.
Session. Thank you, sir, for the presentation. And very thank you.
Thank you, Dr. M.G.K. Pillai. Thank you, Dr. Sriram. I'm sure all of us, especially the students, they would have really enjoyed the talk. It was very concise, and it was quite refreshing to know all about Parkinson's in such a short time.